Thank you, Ian. Good morning, everybody. Thanks to the organising committee for inviting the JLA to participate in this session today. I want to make the case for involving patients in healthcare research debates. There'll be a focus on a model to establish healthcare research priorities. I'll describe a case study in type 1 diabetes, and then I'm going to finish off by making some observations about patient participation in research prioritisation. So just to introduce the team, we're the James Lind Alliance. There's 4 of us. We work about 1 day a week on the project. Our strapline is tackling treatment uncertainties together, and I'll just break that down for you. Treatment uncertainties are questions about the effects of treatments. By tackling, we mean publishing them and then prioritising them. And by together, we mean in partnerships of patients, clinicians and researchers, as Ian has already indicated. We're funded by the National Institute for Research, Health Research, and we're supported by the Medical Research Council. First of all, I just want to make the case for patient participation debates about prioritisation of research. Ian and the James Lind Alliance have published widely on this in several ways about the need for a shared debate on health research priorities, specifically the democracy argument, who pays for it anyway, research that is, the consumerist argument, by talking and engaging with clinicians and patients and carers, service users, whatever we want to use the term, we're more likely to fund relevant and useful research. It's advantageous. Increasingly, research funders are looking for evidence of participation in research proposals, but perhaps most importantly, we feel there is an ongoing mismatch between what gets researched and what patients would like to be researched, and that is summarised very nicely in an article by Talon in The Lancet in 2000. In all my years of working with patient groups and user groups and what have you, I think there are 2 elements to participative debate. I think there's a process element, and I'm talking about methods and tools, a clear outcome, some ground rules, good chairing, so on and so forth. But I also think there's a cultural element. There's a tolerance and respect for differing views. There's a need for transparency and honesty. There's a need for inclusion, however hard that is. And there's a need for using an accessible, transferable language that we all understand. And I think that good participative debate is a balance of those 2 elements. And I think we've developed a model that addresses both of those, and I'll just take you through those 2, the process and the cultural elements. So our process for prioritising treatment uncertainties is, first of all, we gather them, we refine them, we check for uncertainty, we then publish them, we prioritise them, we publish the results of the prioritisation, and then we support the partnerships in funding for those priority research areas. And if you want to know lots more about that, there's some handouts at the front of the room. And also we have an online guidebook which takes you through that process step by step. In terms of gathering treatment uncertainties, I'll refer to Jill's presentation. It's really important that we find out what the research questions are, both from the research literature, and we scan that through research recommendation and ongoing research databases, but also directly from clinicians, patients, the public, healthcare professionals, carers. We predominantly use surveys, but we also run focus groups, particularly for groups of people that are unable to complete surveys or people that are more marginalised. Here's my first debate alert. Okay, my brief for today was to talk about shared debate. And here you'll see, this was a workshop quite a few years ago now, where we were talking with people with type 1 diabetes, and there's a paediatrician there, and there's me before I went grey, talking about type 1 diabetes. And from that workshop, we had 4 other little satellite groups running. We gathered a sense of what was important to people with type 1 diabetes. So the next step in our process is to refine and check for uncertainty. And here's our definition of what we think an uncertainty is, which I guess in this audience, in this room, I wouldn't need to further a debate on that. Sometimes there is a debate on what is an uncertainty, I have to say. It's important that we confront these uncertainties, because otherwise we're denying potentially either unrecognised beneficial care or unrecognised harmful care, or that we're going to waste resources on useless or unnecessarily expensive care. So in a way, by publishing our uncertainties, we are putting them on a map, if you like, an online map of where we think the gaps are. Here's some examples of things that you'll find on the database. They're obviously from different sources, so they're expressed in different ways, and this is absolutely fine by us. It's important they come in as they are defined by the person who's suggested them, and sometimes it's part of our job to interpret them as best we can, but all the time honouring the essence of where they came from. And this is another debate alert. Sometimes in our work, we can spend, 30 minutes talking about one submission, making sure that we're getting it right in terms of putting it into what we call a PICO format. So the refinement is a short sentence, but a very large job to do. When we've decided that we're all happy with what we've got and we're happy that they're genuine uncertainties, they then get put onto Duets, and this is the homepage of UK Duets, which is a web portal, which is part of NHS Evidence, which is part of NICE. On the left-hand bar is your navigation of sort of familiar topics, and across the top is the sources of the uncertainties. We've got about 1,000 there now directly from people and about 2,000 from the research literature. And what's really interesting about this collection so far is that there is an ongoing difference between the nature of questions that we get directly from people and those that we get from research recommendations and ongoing research, which suggests that that mismatch does indeed continue. Okay, so that's our process to begin with. I'll just now introduce our model for what I call our participative model. We call them priority setting partnerships. When we first started in the James and Delights, we used to call them working partnerships, which we thought was a bit stupid, actually, because what do you do in a partnership but work? So we decided to rebrand them as priority setting partnerships, so it was very clear to anyone joining the partnership this is what they would be doing. This is our ideal sort of partnership. You'll see in the middle there's Duets and the JLA supporting the partnership and monitoring what they do. And around the edge are the different groups that we would hope to engage in each partnership, and they would range from professional groups such as Royal Colleges to medical research charities. We'd approach the relevant clinical research network, we'd approach the relevant Cochrane review group, and indeed some of our partnerships have been generated by Cochrane review groups, and we'd also, of course, work with patient and carer groups. So that's what we're aiming for. It doesn't always happen quite like that, but that's our ideal sort of scenario. And I think what we've learnt over the years is that by having this partnership set up in this way, we have by default created a model that is much more about a shared debate than an individual debate. And the way we, I think, achieve that is by asking the partnerships to have some key principles about how they work. The first is that they're inclusive. There's always a balance of perspectives, and in fact it's very important to us that in any meeting or workshop or teleconference there is about the same number of people participating from a clinical, a patient, a carer, or even a research perspective. There's a lot of transparency and I'd hope democracy in our partnerships. We share our data, we agree a protocol, and we declare our interests. And I think we are evidence-based. We're working with known unknowns. We're working with things that we know are genuine research questions. We're not repeating stuff that's already been done. And also there's evidence in the patient and carer experience and, of course, clinical behaviour. That's all part of our evidence. This group here is the schizophrenia partnership. In January, we were reviewing treatment uncertainties. I think we've got our whole list there on the ground. We're obviously not quite reached our 10 yet, but I'll talk a bit about how we achieve our top 10 in a minute. It's really important that we talk as part of the debate. That sounds such a stupid thing to say. Of course you talk in a debate, but I mean by talking, listening, sharing, and respecting different views. A professional might say, why is there non-compliance of antipsychotic drugs in young men with schizophrenia? Perfectly good question. The young man with schizophrenia might say, I take a break from my drugs because they make me impotent, and sometimes I want a sex life. So you're talking about a compliance issue, but they're coming at it from very, very different perspectives. And I guess what we would hope to achieve in our partnership work is that we get to the bottom and get under the skin, if you like, of all these treatment uncertainties that we're prioritising so that we do have a shared understanding. Now that little example has been published as part of an article in Nature called Democratising Clinical Research. And Keith Lloyd, who's the main author of that article, would fully admit that it's changed the way he thinks about non-compliance of treatments in schizophrenia, particularly in young men. Okay, I just want to throw some numbers at you now. This is a typical partnership. Well, it's not typical, but it's one of our partnerships and how we progress through the data. So this is type 1 diabetes. You'll see on the bottom of the slide, you've got all the different organisations that are represented. We also had individuals representing particular perspectives, which was important. So we started off with a survey. We had a workshop to generate some topic ideas, and then we followed that up with a survey. We had 583 respondents, and that was a very representative spread of type 1 diabetes, both patient and clinical population. And over 1,000 uncertainties were expressed. We then added 118 that were sitting on UK duets, and then we took out 251 that were not related to treatment. Very interesting questions, but not related to the effectiveness of treatment, so they came out of the prioritisation process. We then started to refine and analyse what we were left with, and there was a lot of unique treatment uncertainty questions. In other words, there was one person suggesting one question that was sufficiently different from everything else to make it unique. So we decided to take those out of the prioritisation process, which is a bit harsh, but you know, the whole point of prioritisation is you're funneling down and you have to jettison things as you go along. But the steering group agreed this was the right thing to do. We were then left with a whole bunch of questions that were groups of questions and sufficiently similar enough to combine. And I think we would bring to bear here the sort of general rule of thumb around systematic reviewing is it similar enough? And that left us with 88 what we call indicative questions. And there's a huge amount of debate at this stage about formulating an indicative question that captures what may be the content of 60 related submissions from the survey or from the workshop. The steering group agreed 47 from that 88 based on various criteria that we had pre-agreed. And we sent that out for voting to all the partners that had previously filled in the survey. That gave us a short list of 24 based on votes and further steering group discussion. So getting back to Jill's presentation, it was a combination of voting and discussion, which I think is a really interesting feature of what we do. We then took those to a workshop to discuss and agree a shared top 10. That's our bottom line goal when we're working on this. Currently, the steering group have taken feedback on that top 10, and we're reformulating them for taking forward to the next step. Here's the pictorial evidence of the workshop. It was in, I think, June this year. You'll see on the left-hand side, we're working in smaller groups, and we're sort of beginning to get a sense of, out of our 24, what can we all agree sits at the top. What usually happens, people agree what sits at the top and they agree what sits at the bottom, and then there's this whole bunch of stuff in the middle that needs sorting out. So that's how it was sort of panning out. And it's all about the debate at this stage. This is what I call debate-tastic. It's just all kicking off. It's great. And it's really important that the facilitators in this, which is the James Indy Alliance facilitators, are keeping a handle on that discussion and what's happening. You'll see towards the bottom right-hand corner of the slide, there's a picture there where we've reached about 14. I think we've got 4 to get rid of. So we're nearly at the top 10 stage. I think that was about 3 o'clock, and we're all beginning to feel a bit tired and need some refreshment. So that's pretty much what happens in a workshop. It's called nominal group technique. It's well written up, and that's how we achieve our top 10 shared uncertainties. I just want to make a few observations about shared debate in prioritisation. And this is from our own experience of running over 7 of these partnerships now. There's a tension between the importance of a treatment uncertainty versus the researchability of the question. And at the moment, we pretty much sit in the former camp. We are mostly interested at this stage in what this means to either clinical environments or patient environments. And some patients would say, it's our job to work out what really matters. To us, it's the researcher's job to sort out the research study. And there's some validity in that, I think. But clearly, we do talk a little bit about researchability, but we don't focus on it. There's a balance to be achieved between research priorities that address the greater good and potentially have the biggest impact, but there are also very significant smaller populations affected by treatment uncertainties that need to be heard too, and that's a genuine balance in our work. We always have single issue participants, and they're not always patients. They're very often clinicians or researchers. And our job is to manage that. So they're heard, but they're not heard all the time. Sometimes we've been better at that than others, but that is a common feature of this sort of work, and I think we just learn how to deal with it. We also learn how to deal with hierarchies that exist both within clinical, research and patient communities. And again, it's a fine art of facilitation, and that's where I think the neutral facilitation comes into play. The James Lind Alliance has no vested interest in what happens with those, what the nature of those top 10 are. That's not our job. Our job is to make sure the process happens well, everyone feels heard, and we achieve the outcome. So this is where we are with our current experience. On the left-hand side, you'll see that's the partnerships that have completed. And on the right-hand side is where we are with our current partnerships. And we're just about to add dementia to that list. We've just heard dementia is probably going to happen fairly soon. So very different types of conditions, throwing up very different types of questions in the top 10s, but there are themes across them. And here they are. Long-term effects of treatments, safety and adverse effects of treatments, using non-prescribed treatments, particularly alternative therapies, stuff you get on the internet. Professional training and education, this particularly for early diagnosis and treatment, and also to harmonise clinical behaviour, which is, I suppose, a very polite way of saying postcode provision. And self-care, effectiveness and safety. Now, we can't say this yet, but I would suggest that this is possibly the difference that a shared debate can make to a set of research priorities that might look very different if you either had a group of patients in a room or a group of doctors in a room and nurses and other healthcare professionals. Our final step then is to apply for funding for priority research. We don't apply for it, the partnerships apply for it. And here's a quote from Stephen Holgate, who's chair of the UK Respiratory Research Collaborative, who feels that a priority in breathing exercises would never have made its way to the top of a list and indeed is now going to be funded as a trial had we not adopted this sort of approach. So, if you want to find out more, that's our guidebook web address. We have a more general website address with more background information, and also I've also helped to write a toolkit for patient and public involvement, and there's a free copy for anyone who can tell me at the end of this session, the whole session, who James Lind was. Thanks very much.